Okay. So we are going to study that the chlorpromazine as a prototype, it had all these effects. That is not only anti-dopaminergic activity, but they have many other activity. That's the first point. The next is the local anesthetic activity it has, but it is not used as a local anesthetic because of the irritant action, and other antipsychotic drugs have weaker or no membrane stabilizing action. So all other antipsychotics, whatever we studied, that haloperidol, flupentixol, and clozapine, olanzapine, so all those things, they do not have any membrane stabilizing action or local anesthetic action. Cardiovascular system, yes, they act on the cardiovascular system. They are neuroleptics. They're called as neuroleptics. Produce means antipsychotics are called as neuroleptics. Neuroleptics produce hypotension, mainly postural, by both central and peripheral action on sympathetic tone. So there is a sympathetic tone acting on the heart. So these drugs act on the sympathetic tone and cause postural hypotension. Okay, that means suddenly if the person is waking up from the sleeping position, that goes for a hypotension and then dizziness and all those things. That is postural hypotension. Postural hypotension is caused by these neuroleptics, antipsychotics, by both central and peripheral action on the sympathetic tone. It roughly parallels the alpha adrenergic blocking potency. Okay, so that means it is comparable to the alpha adrenergic blocking action, because we know that alpha receptors are the one which causes vasoconstriction and cause a vascular tone to be in the normal state, so that there is a proper blood pressure. If thus alpha adrenergic neurons are blocked, then there occurs vasodilation, the sympathetic tone goes off, and there will be fall in the blood pressure. Partial tolerance to hypotension action develops after chronic use. Reflex tachycardia accompanies hypotension. So these are all the causes, these are all the actions on the cardiovascular system. High doses of chlorpromazine directly depress the heart. This is an additional added problem. So low dose, it causes on the sympathetic tone and it decreases the blood pressure and the heart rate and all. But high dose directly depress the heart and produce ECG changes, QT prolongation and suppression of the T wave. Chlorpromazine exerts some antiarrhythmic action also due to membrane stabilization. They have local anesthetic activity due to membrane stabilizing action. We heard that. So likewise, they do produce the antiarrhythmic action due to membrane stabilization. Arrhythmia may occur in overdose, especially with thioridazine. Okay, arrhythmia may occur in overdose, especially with thioridazine. Skeletal muscle. Neuroleptics have no direct effect on muscle fiber or neuromuscular transmission. However, they reduce certain types of spasticity. That means in the skeletal muscle also it has an inhibitory activity. No direct effect, but they reduce certain type of spasticity. Heart, it is reducing the activity. Skeletal muscle, it is reducing the activity. Site of action being basal ganglia or medulla oblongata. For skeletal muscle action, where it is acting at the basal ganglia or the medulla oblongata. Endocrines, do they have action on the endocrines? Endocrines, yes, neuroleptics consistently increase prolactin release by blocking the inhibitory action of the dopamine on the pituitary gland. See, dopamine from down to up, it is acting in a reverse direction. It is acting on the central nervous system. It has an inhibitory action. So that is also blocked. When that is blocked, the inhibitory effect is taken off from the pituitary gland, and that goes on secreting the dopamine, causing in turn causing gynecomastia and galactorrhea. So they reduce gonadotropin secretion, but amenorrhea and infertility can occasionally occur. Okay, so acting on the gonads, they reduce the gonadotropin secretion, but this gonadotropin is at the central. So they reduce the gonadotropin secretion, but amenorrhea and infertility occur occasionally. ACTH release in response to stress is reduced. Corticosteroid level fails to increase. So another endocrine action is release of growth hormone is reduced, but not sufficient to cause growth retardation in children or to be beneficial in acromegaly. So acromegaly is excess growth hormone secretion in adults. So if it is known to cause a decrease in the growth hormone release, but it is not useful in acromegaly. However, it is not causing the growth retardation in children. Decreased release of ADH, antidiuretic hormone, may result in increase in urine volume. Okay, urine volume may increase. Generally, do not affect blood sugar levels. Chlorpromazine and few others have potential to impair the glucose tolerance and aggravate diabetes, often associated with weight gain and insulin resistance. So, this is with regard to inability to interfere with the pancreas activity. So almost all of the endocrines are affected. Uh, if you just see from here, from the starting from the pituitary is the main endocrine gland. Pituitary is affected, and then the amenorrhea and infertility is are done. Okay, acting on the ovaries and all those things, and then ACTH, adenocorticotropic hormone, their level fails to increase, and then growth hormone. Okay, so growth hormone, though it is reduced, its effect is not significant. That is one thing. Decreased release of the antidiuretic hormone is seen, and hence increase the urine is maybe seen. So it acts on the pancreas and impairs glucose tolerance and aggravates diabetes. So almost all endocrines it acts and has actions, antipsychotics. Tolerance and dependence. So tolerance to sedative and hypotensive action develops within days or weeks. Tolerance means where they're able to show no effect to the previously responsible dose of the drug. Okay, so previously it was responsible for, it was showing a response at 5 milligram. Now also it is showing a response at 5 milligram. But the third day, fourth day onwards, no response to 5 milligram. That is tolerance. Dependence is, it is showing a response only to the additional dose. Okay. So tolerance to sedative and hypotensive action develops within days to weeks. However, maintenance doses remains the same over years. The antipsychotic, extrapyramidal, and other actions are based on dopamine antagonism do not display tolerance. Neuroleptic drugs are bland and do not produce psychological dependence. Mild physical dependence may be seen. So that means due to the taste, there is no dependence, but physical dependence may be seen. That means their body might have accustomed, say for example, it might have been showing some dampening effect on the neuromuscular conduction or in the thought process. So sometime like that. So if it is withdrawn, it manifests as tremors, rigidity, and kind of a thing. So that is physical manifestation. That is dependence. Dependence on the chlorpromazine may be there. Now coming to that, all that was pharmacodynamics. Now coming to, let us see the pharmacokinetic aspects. Oral absorption of chlorpromazine is somewhat unpredictable, and bioavailability is low. More consistent effects are produced after IM and IV. Okay, so orally when you give, the absorption is unpredictable. But if you give IM or IV, the consistent effects are produced. Highly bound to plasma and tissue proteins. So once inside the body, it is highly bound to plasma and tissue proteins. Brain concentration is higher than plasma concentration. Volume of distribution is large, 20 liters per kg, and metabolized in liver by CYP2D6, that is an enzyme. So this is the enzyme which is known to occur a lot of enzyme reactions. So likewise, if they use any drug inducing or inhibiting this enzyme along with antipsychotics, there will be similar changes in their manifestation. So the pharmacokinetics of all other antipsychotics are more or less similar. Okay, so that is why it is continued like that. So the acute effects last for 6 to 8 hours. The chlorpromazine 6 to 8 hours. T half is 2 to 18 hours. T half is 18 to 30 hours. It's very long acting, and drug accumulates on repeated administration. The intensity of antipsychotic action is poorly correlated with the plasma concentration. That means the whatever the actions it brings about is in no way related to the blood concentration. Okay, with small concentration in some people, there may be very high effects. With high concentration in some people, there may be few effects. So there is no concentration. Therapeutic effects may be seen at 30 to 200 nanogram per ml plasma concentration. Metabolites are excreted in urine and bile. So whatever all this happens after this, metabolites, whatever they come out, they are excreted in urine and bile. So all phenothiazines, thioxanthines, butyrophenones have the same antipsychotic efficacy. Now we are talking about the other few drugs, whatever we left it out in the list. Okay, all other drugs, how do they act? Let us try to understand. So keep chlorpromazine as a base, and whatever it acts as a in your mind as a thing, and based on that you are going to think about the other antipsychotic drugs. All phenothiazines, thioxanthines, and butyrophenones, these are all the different classes of drugs, antipsychotics. They have the same antipsychotic efficacy, but potency differs in terms of equi-effective doses. Okay, the aliphatic and piperidine side chain phenothiazines, chlorpromazine, triflupromazine, thioridazine, they have lower potency, they produce more sedation and cause greater potentiation of hypnotics and opioids. The sedative effect develops promptly while the antipsychotic effect takes weeks to develop. So in all these drugs, the sedative effect, as soon as you give the person doses, so that is more well seen rather than the antipsychotic effect, which takes time. Tolerance develops to the sedative, but not to the antipsychotic effect. Luckily, so after giving it for a few days, tolerance develops to the sedative effect, but not for the antipsychotic effect. Extrapyramidal motor disturbances are closely linked to antipsychotic effect. Okay, extrapyramidal motor disturbances means whatever is the rigidity, stoopness, tremors, all those things they are closely linked to antipsychotic effect. Sometimes, if you given more antipsychotics, the drugs causes these kind of and Parkinsonian behavior more. So some close notes about some of the drugs. Haloperidol, as I said, keep it in mind. It is a very important drug. In most of the psychiatric emergencies, what the drug is administered is haloperidol. Reason it is a potent antipsychotic with pharmacological profile resembling that of piperazine substituted phenothiazine. So just leave it. It's a most potent antipsychotic drug. Triflupromazine, the aliphatic side chain phenothiazine, more potent than chlorpromazine, used mainly as antiemetic. So even though it is antipsychotic, it's mainly used as antiemetic. Okay. Thyroidazine, low potency. Low potency phenothiazine having marked central anticholinergic action. Risk of eye damage limits long-term use. Triflupirazine, flufenazine, a high potency piperazine side chain of phenothiazine. They have minimum autonomic actions and cause jaundice. Triflupiridol, it is similar but slightly more potent than haloperidol. Penfluridol, exceptionally long-acting neuroleptic recommended for chronic schizophrenia. Flupentixol, infrequently used now. Pimozide, it's a specific dopamine antagonist with little alpha adrenergic or cholinergic blocking activity. It has been used particularly used in Gilles de la Tourette syndrome. Loxapine, a dibenzodiazepine having chlorpromazine-like dopamine blocking and antipsychotic activity. And apart from this, a wide list of atypical antipsychotics such as clozapine, reserpine, quitipine, and olanzapine, clozapine. Okay, so those are the atypical antipsychotics. So we have come to an end to this part one of the antipsychotic effect. I hope all of you have written their name and typed their roll numbers. So in a net effect, since you are being introduced to psychiatric illnesses for the first time, you need to understand that psychosis and neurosis are two broad categories. And psychosis is when where dopamine is abnormally high in basal ganglia, and neurosis, not much stress is seen, but still they disturb themselves. Okay, the prominent psychosis includes schizophrenia, paranoid states, hysteria, and things like that. And neurosis, obsessive compulsive disorder, mania, depression, and psychosis. So these kind of things. So the entire drug group itself is called as psychotropic drugs. So there are different classifications under that. We focused only on the antipsychotic drugs. Antipsychotic drugs, again, a lot of classifications. And these antipsychotic drugs, they act by blocking the dopamine receptors. Any doubts, any clarifications? You have to go and read at the home. I mean, you're at the home only, but you need to read. Otherwise, it will all evaporate. Okay, any doubts?
No, sir.
Okay. Have a nice day then. Enjoy your day.
Thank you, sir.